of Alzheimer's Coachella Valley. And traveling the journey really is, since we have modified it because of COVID, is really a resource and skill enhancement for our families, caregivers, and professionals in the community. And I think it's important to talk a little bit about ACV's philosophy in terms of working with our families and working with those that have cognitive impairment. So our focus is always on not so much on the disease, but on the people involved in that family unit. And we try to emphasize the possibilities and the abilities that those folks still have access to, and introduce resources and whatever else, solutions, skill enhancements that will make their journey a little easier for them. So in keeping with that philosophy, I think there's three really important things that we're going to emphasize in the presentations today, and that is best care practices. So focusing on the individual, focusing on personal rights, focusing on privacy and dignity and respect. And so hopefully the presentations today will reinforce that. I think we all would accept that being human beings, we are all sexually involved in being a human being. And the fact that somebody is diagnosed with Alzheimer's and dementia does not mean that those folks still don't have those same emotions, desires, and wants. And the focus here today is going to be on not so much on how their behaviors, which are impacted by the fact that they might not have good judgment, not so much on that. In judging that behavior, there is no right or wrong. What we're focusing more on is ourselves as caregivers, providers, friends, and coworkers, on our response and our reaction, and how to make that more, as we talked about, respectful and dignified, while also honoring their personal rights that they have access to. So the panel today, I'm happy to introduce, we have three presenters, and I've worked with all of these folks, and they have a wide variety of experience that I think will shed some light on our topic today. So presenting first is Jack Poyfair. Want to give a wave, Jack? Jack is the executive director at Vista, Cove in Rancho, Mirage, which is a dedicated memory care community. And Jack is a nurse himself. He's been the executive director since 2004 and has lots of experience in the assisted living memory care community. And our second presenter is Mandy Calvano. Mandy, there's the wave. Mandy is the owner of Custom Care Solutions, and that is a home care agency. So some of you may be accessing services like that in your home right now, or that may be a resource that you would use later on in your travels. So Mandy is going to use her experience with providing caregivers that are introduced into your home situation and shed some light on that. And our third presenter is Judy Rhodes. There's Judy, and Judy is an RN. She's a board member at Alzheimer's Coachella Valley. And as a volunteer, she spends a lot of her time with our families, trying to help them resolve and come up with solutions when they're still existing or their family members are still at home, and it's more of a one-on-one situation as opposed to being in placement or having a paid caregiver come into their home. So Judy's going to relate some of those experiences that her families have shared with her. So we'll have time at the end after each presenter has their time. We'll have time for questions and answers. However, if you feel more comfortable going to the chat box and putting your question in, you're more than welcome to do that. We'll make sure that that gets addressed at the end of the session. So I'm going to turn it over to Jack Poyfair.
Good morning, everyone. Pat gave me a pretty good introduction, so I don't think I need to do that. So we'll just jump right in. Little bit of numbers and statistics. In general, people are likely to have a behavioral or psychiatric symptom when they have Alzheimer's or dementias, 50 to 80% of the time. The occurrence of inappropriate sexual behavior is anywhere from 7 to 25% of people. It's noted to be higher in residents of assisted living, skilled nursing facilities, and in patients who have more severe cognitive impairments. And these are all statistics from the National Institute of Health. There aren't really any good studies on how many people actually have this. The medications are all anecdotal and case study information. So keep in mind, this is something that hasn't really been well studied. So some of this is just best guess as far as the numbers go. Before we start in on how to handle sexual behaviors and medications and those sorts of things, a couple of things. Keep in mind that not every behavior that somebody exhibits, we may see it as sexual, and it may not be. So it's really important not to take any behaviors personally or make assumptions. One of my best examples, we had a gentleman in a board and care, and they wanted him to move because he was being sexually inappropriate. So I went to assess him. He was ambulatory. He was not very verbal. No, none of his words made sense past hello or yes. So he was disrobing in the living room, and they would, put him in his bedroom and say, no, no, no. And then a little while later, he'd come back out and walk into the middle of the room and pull his pants off. And the caregivers would say, no, no, no. And then all the other residents in the living room would look at him and say, oh, he took his pants off. Get him out of here. Well, it turns out that behavior had started when he became incontinent. So when he moved in with us, he would walk out, he'd be sitting in a chair, seemed to be fine. Then he'd walk out where everybody else was and start taking his pants off. So initially I thought, well, he just needs to go to the bathroom. He wasn't doing anything else overtly sexual. But it turns out he was wearing blue jeans. And when he started having to wear Depends, it was just tight. And the first time I took him to the bathroom, I was like, obvious his pants were tight and he was uncomfortable. So a pair of sweatpants solved that issue. He wasn't being sexual. He just couldn't tell anybody that he was uncomfortable and needed his pants off. So anyway, just to keep that in mind before we get started. And again, as we discussed, dealing with behaviors and treatments, the goal isn't to stop sexual behavior entirely. It's to try to get people to manifest their sexual behavior in a way that's appropriate and isn't distressful to other people. Like all things, we always want to start with non-pharmacological treatment. That can be divided into a couple of different categories, environmental and behavioral, and a little bit of educational. Environmental is probably one of the simplest and most obvious things. What can we do in the environment or what's around that person that can lessen inappropriate behaviors? Often it's as simple as, instead of having a female caregiver with a male resident or patient, switching that out to a male caregiver. Sometimes people just need to be in a room by themselves and away from other people. That's, simple things you can do. Part of that is also providing an appropriate space for sexual expression. If a resident is masturbating and they're doing it in a common area, you don't want to make a big deal or scream and yell. It's just, hey, come with me. Let's go to the bedroom, and that's a good place to do that. You want to have everybody who's working with the person be consistent in their approach. And a lot of that is not getting excited. You know, obviously we all know if you get excited or your tone goes up or you yell when you're dealing with somebody with dementia, it escalates them, and then you're just in a negative loop. Some of our residents have responded to cues that help remind them that it's inappropriate. I've had several female caregivers that when male residents are inappropriate with them, they'll start calling them grandpa or grandfather, and they don't make it a big deal. They just say, okay, grandpa, we're not doing that. Help me with this. Those sorts of things. Sometimes when you're in public, if they're making inappropriate comments, you can say things like, well, she kind of looks like our granddaughter, or, you know, oh, that's a friend of mine. Some other things to redirect from what they're saying. And the goal is not to shame people or make them feel bad or guilty. There's ways you can sort of remind people that this isn't the time and place for that. And then just physically redirecting people, and certainly asking for help is always a good one. You know, it's okay, help me take this letter to the mailbox before the postman gets here, before we run out of time. Come up with a time-sensitive task that needs to be done now. And you're not really saying we'll do that later. It's just we need to do this now, and get a task. Anything with walking or keeping hands busy, folding laundry, can be effective. Not always, but you got to figure out what works. As far as education goes, it's really mostly for family and caregivers. We have a lot of young caregivers that start with us, and some of them are absolutely shocked to find that people over 30 have sex. They just can't, they literally did not think that was going to happen. That would be something they'd have to deal with. And once they have some education and understand that, you know, like eating and breathing, for most people, sex is a lifetime thing that happens. You know, comes and goes, but usually people have those feelings regardless of where they're at. So once they understand that, it makes it a little easier to have them help people be appropriate with what's going on. Medication treatment, again, there really are no good studies on this. It's all anecdotal and case study evidence from personal experience, trial and error with meds. There are things that are effective. Antidepressants such as Paxil, which are known to have a side effect of decreasing sexual desire in people who take it for depression, is often used. There's a lot of other meds such as valproic acid, gabapentin, Tegretol, Haldol. Sometimes the newer antipsychotics are used with varying degrees of success. A lot of medications take a couple of weeks to kick in, so you have to be patient. And then if something isn't working, you might have to switch to something else. And any conversation about medications, or, you know, when you're thinking about that, that's really a conversation to have with your physician who knows what's going on. A lot of medications have different side effects, which, depending on, you know, what your physical condition is, might be a bigger deal than some other medications. So that's certainly a good conversation to have with your physician. Really don't do much hormone therapy. That's considered pretty a drastic measure. In 15 years, I've only had one patient that, you know, the physician decided that hormone therapy was appropriate to decrease that. Okay, and I'll turn it over to Pat again. Am I on mute or are you on mute? Me?
No, you're not.
No, it was me,
Oh,
Jack.
okay. Usually it's me.
Thank you. And now we'll hear from Mandy Calvano.
Hey, thank you, Pat. I've been doing in-home care for about 25 years. So I've had a lot of experience going into people's homes and seeing different behavior, but I want to start off by telling everybody, put your arms out wide. This is your vision at age 20. You have peripheral vision, you have motion to turn, look. Age 40 comes in a little bit more. Start to see a little less peripheral vision. In your 60s, you're more here. With dementia, you're more here. And as you're getting into the end stages of dementia, do this. Now you're here. I'm going to do something obnoxious. So now you have vision like this. And what do you see? Okay, sorry. So some things that we experience with people are more what they're going through when it comes to the changes in dementia. So now you see this vision that's come down to here. In the very end stages, you go down to 1 and then none. So vision is a big part sometimes of maybe what's being verbally expressed. And this is one of the things that I've learned in observing our clients. So now you have this very limited vision, but you've also lost something else. You've lost your ability to find words. Depending on the stage of dementia, you may be in a stage of dementia where you're only getting 1 out of 4 words. So now you're grasping for what you can hear and what you can express and what you can see. So you may look at somebody's top and say, nice boobs, because those are nice flowers. But boobs is one of those forbidden words that we store back here that we don't always, that we pull from. So in one of the things I want to remind everybody is sometimes, like Jack said in the beginning, sometimes a behavior is the only type of expression that's left to communicate with. And as shocking as it can be for the caregiver, for the family, those behaviors are something to pay attention to, because it may be a very, the only way to express a need. With that being said, there's still the desire. Younger and younger people are being diagnosed with Alzheimer's. And, you know, typically by the time some people were diagnosed 20 years ago, they were in their 80s and 90s. So some of these desires we didn't see as much, but we have a lot of younger patients now. So what I've noticed is sometimes people just need their space, their privacy. So what do you do when someone's inappropriate? Like Jack said, do we overreact? Do we yell? Do we say no? I find it's a lot easier to take that person to an appropriate place and let them have their space. One of the things that I'll say that I've had experience with is we had a client that would need time alone in his room. And the family would want us to stop that time. So we have to say why. Why do we want to do that? Is it necessary? Is the behavior hurting somebody? Is it hurting the patient? And the answer was no. It wasn't hurting anybody, it wasn't hurting him. And so it's important, like I say, that we look at each individual and what their needs really are. How do we train ourselves to get ready for this? Because that's what I find the most disturbing part is. Am I ready to have a conversation with a caregiver about how a client is talking to her inappropriately? And what are we going to do about that? And so usually, like I say, we sit down and we talk about what is the person's behavior. Is it inappropriate touching? Is it inappropriate words? Is it an actual sexual act of masturbation? Are they trying to get after their spouse? Which this is important to me to say. You, as a spouse of somebody with dementia, there may come a point where you're not comfortable, and that's okay. I have had caregivers in that situation where the husband is after his wife, the wife wants nothing to do with them, and they say, what do I do to stop this? How do I help? So again, it's being able to talk about these things, put together a plan of care, because this is something that needs a plan of care. and address, like I say, is the behavior inappropriate? Is it going to hurt somebody? And if not, then let's go ahead and let that patient have their privacy and their rights. I find that our caregivers are very understanding of these behaviors. So I really want to reinforce to everybody today that as embarrassing as it seems to be for you, the family, it is something that we are used to dealing with. The caregivers know that there's limited speech. They understand that there's limited expression. Some clients have a real sense of humor and they think they're being funny. We had a patient that, and I have to say, we had a caregiver that was extremely large breasted. I mean, it was unusual. And our client was the life of the party kind of guy. And he was always making jokes and he was always hitting on everybody and he was always having a good old time. And this caregiver, he really liked her. He was really nice to her as a person, but his comments would get more and more inappropriate. And, you know, we did determine that it really was his sense of humor. And so we had to kind of redirect because he would get on this roll of all these obscenities and thinking he was making jokes. And so everything came down to, we would just redirect him when he got to that point. We tried things like taking the caregiver away, but he wouldn't get along well with anybody else. So she decided she could handle his jokes and just redirect him. So redirecting is a big part of this behavior as well. But I really do want to reinforce that the changes that that person's going through in their brain, in their body, has a lot to do with where they pull from for these words, for these behaviors. Like I say, those forbidden words are the last they lose. And you have the rhythm of speech. So it may sound, there's times where it may sound like someone's making sense. Hi, Jack, hi, Jack, hi, Jack. Jack, you look nice today. You look nice today, Jack. Jack, take your pants off. It's not, there's a misconnection of speech, but the rhythm's there. So the conversation is happening for that person, but the words aren't right. So I find that with speech, that's a lot of what's going on. There's a lack of being able to communicate. Groping and touching, well, let's face it, with dementia, some things feel good. So find a stuffed animal that person can hold, or keep their hands busy while you're having to help them change or dress or something like that. We have a lot of different things here in our office that we use, that some are like aprons that go around somebody's waist and has buttons and zippers and snaps. And, you know, sometimes it's a need to just have their hands busy so that they're occupied. So I think I'll turn it back over to Pat.
Thank you, Mandy. And now Judy Rhodes.
Good morning, everybody. I'm going to, in my voice, be yelling at you because I talk too softly. So cue me if I'm too soft, Pat. But yes, I am a family caregiver. One of the things that struck me when asked to talk on this topic is how personal and private talking about sex is, especially for us in the older population. It's something that's very personal and private, and yet sexual behaviors and sexual satisfaction has been present since we were little children. And so it's, as Jack and Mandy have talked about, it's very natural and normal. It's when the person with diagnosis loses their filter or begins to act in a sexual way in inappropriate places or with inappropriate people, that it may become a problem. It is a concern and it causes distress both for the family as well as for the person with diagnosis. It's also important to remember that while they don't have a filter, they also may become impulsive in their actions. And so they may catch you off guard. And so some examples that I've seen that may apply to those of you that have a partner that have diagnosis or working in the field. Sometimes it will be a comment about a loud comment about someone's sexual butt or sexy butt, or as Mandy was talking about boobs, something like that out in public places. I know that in my family, we've had to redirect my granddaughter's grandpa in making comments about her growth and development, and have to have a family conversation with my daughter and her husband that they help in redirecting those kinds of comments that are really inappropriate. When we go to the doctor's office, oftentimes there's a comment about wanting to see the female receptionist's pretty face because she's wearing a mask with COVID. Can I see your badge? Because I can't see your pretty face. So it's kind of a subtle comment, but could definitely go the wrong direction if it was left to fly. One of the other things that happened in our situation that was, again, those of you that know me, I'm on the journey with the rest of you. And so while I may think I can anticipate a problem, sometimes I am surprised. And so there was an opportunity for my husband to play Santa Claus a couple years ago. And he was really thrilled about having the mom sit on his lap. And he thought that was just really funny. And I remember him talking about it in Club Journey, and it was really inappropriate. And so trying to make sure that there's a way to kind of stop that before he gets into trouble. And so does the person that he's talking with. So again, redirecting, it becomes really key, and being really present with them when they're out in public. When it comes to the private places, again, seeking comfort and being close and touch are so common needs for us. And probably even more so as we continue down this journey with Alzheimer's and dementia. So I think that that's a piece that I wanted to stress, is that it's just part of our being. And with disease and illness, for some people, passion may be replaced with compassion. And again, there are two people that are part of this partnership. The one person may be very passionate and the other person is not. And it may be due to illness. They may not be able to perform any longer sexually. And so trying to find some way of providing that human touch is really key, I think, for family members. So it may be a hug, it may be cuddling on the couch, it may just be crawling into your comfy warm bed and snuggling and enjoying the fact that you still have that relationship. It's important to be, as Jack and Mandy have talked, and Pat too, that they have a right to finding comfort in their own way. It's just important that they do so in private, and being aware that the partner should not be endangered in any way. And I guess finally that it may be important to seek professional help. I can see as a caregiver, maybe a therapist, like a licensed family therapist may be helpful as far as trying to find some strategies. As Jack mentioned, maybe medication, for both partners, the caregiver as well as for the person with diagnosis might be helpful. But it is a very sensitive subject, and one that requires some thought. And again, just like the disease, it's such an individual situation. So feel free to chat with us. I don't know that we all have the expertise, but we may be able to do some things to help you deal with the situation that you might be facing right now. So back to you, Pat.
All right, thank you. We have time now for people, if anyone has questions. Or Priscilla, did anyone type questions in the chat box? Okay, if you have a question that you would like Jack, Mandy, or Judy to address, you could just raise your hand and we'll acknowledge you.
Okay. Rob Weiser, you can unmute yourself. Go ahead.
I will. This is probably directed to Jack because it's probably more on the lines with you know, a memory care facility. And when you talk about privacy um, are you talking about just allowing that individual person to have the private? Um, what if the spouse and the client both want it? You provide the private place for them. But what if it gets more complicated where two residents want to canoodle?
Actually, I've had both those situations. Spouses, certainly, of course, that's an easy one as long as the affected person is consenting and willing, and that's, you know, usually pretty easy to tell. Have had situations where residents meet each other in the community and want to have more of a relationship. So again, as long as they're both seeking each other out and it's consensual, I talk to their responsible parties and let them know what's going on. A couple times I've had family members be what I would consider to be unrealistic and not want them to have that kind of companionship. My best example is a couple of residents were holding hands and spending a lot of time together, and their families knew each other and they took each other out, and they came to me one day and they said, "We want some private time." And I said, "Okay." So I called both families in and said they'd like private time, so I'd like to give that to them. And you know, they said, "What are they going to do?" I said, "I don't know. It's going to be private." And they agreed that that was okay. So we had a plan, and it was, and these were folks that were pretty moderately impaired. But they had, you know, a time where the sign went on the door, and, you know, they knew they had half an hour and nobody was going to bother them and leave them alone. Eventually, they did end up living in the same room together. And actually, that gentleman had some really significant behavior issues. And I always kind of look at, you know, when people have negative behaviors, what is their unmet need? There's a reason they're acting out. And really, I think his unmet need was he just wanted to be loved. He had to have somebody's hand to hold. He wanted to lay down next to somebody. I don't know, you know, what they did. It was their private time. I suspect it was just being near somebody. And then when that need was met, he had no negative behaviors, wasn't aggressive, was cooperative with care. Actually, they both had a really nice, the end of their life. You know, we often think how horrible everything is when you have dementia and you lose everything. They had a really good time for quite a while, and they were happy. They got what they needed. They got love, whether that's, you know, physical, emotional, you know, all those things. That's what everybody wants. I have had families that, you know, I had one man who would seek out one lady and they would hold hands. That's all they did. They didn't do, he wanted somebody's hand to hold. His wife couldn't tolerate that and she moved him somewhere else, which is, I'm sure he found a lady there to hold a hand.
Okay. So could I have one quick follow-up question then?
Sure.
If the resident is gay, are the same guidelines and evaluation done? And can you speak to the education of the staff on that?
Let's see. I'm 54 years old. I became a nurse when I was 20, and what a different world we live in now. I don't really have to, you know, we hire younger caregivers a lot of times, you know, people in their 20s. The difference in attitude, and I mean, being gay is just such a non-issue for the staff taking care of our gay residents. I mean, they don't treat them any differently. I do have a few gay residents, and sometimes they're sexually inappropriate or borderline inappropriate with the young straight caregivers working there, and the straight caregivers don't, I mean, it just doesn't bother them at all. It's just such a different world.
Okay, good. Good, thank you.
Jan, thank you, Rob. Jan Parker, do you have a question?
I think this is probably for Jack too, but I was wondering about COVID now that, you know, patients aren't getting hugs from families and feeling the touching. And I was wondering if that's made an impact on the clients.
Sadly, it has. I've had some occasions where we had to isolate a particular resident because they'd been exposed, and for somebody with dementia to be isolated it's just horrible. It's just so difficult. You do see people decline. As a memory care facility, you know, our residents aren't going to wear masks. They're not going to social distance. So at one point we said, okay, you know, we're going to cohort people in little groups together. And that's going to be the best that we can do, because touch and socialization is absolutely a basic human need. We're at the point now where we're doing socially distant outdoor visits. We've all been vaccinated, had all our shots. We have had COVID there, so I think a lot of people had antibodies. Only had one round. So I do think we're getting, you know, the CDC says they're going to put out recommendations on what people who can be vaccinated can do. So I'm really hopeful that's going to change. It's really been difficult for spouses and kids not being able to touch the people that they love. And we went many months without, it was only Zoom visits. So now at least you can physically see people, which is a whole lot better than nothing.
I want to respond to that too, if I can. We've noticed even with in-home care that decline because family members aren't coming to visit. You know, they don't want to take the chance they spread the virus. And it's been very hard on our clients, feeling isolated, disconnected, like you say, not having that hug from a family member. So the caregivers have really stepped up to fill an even greater emotional need. And one of the things I've noticed is we have slowed down. Maybe we don't do as much housekeeping because we're taking more time sitting with somebody, holding their hand, because we really are the only person they've seen in almost a year. So I've noticed that asking my staff to slow down and make sure that the person is getting physical contact, attention, eye to eye communication has helped in some cases. But yeah, it's a lonely time right now.
Dom, go ahead. You'll have to unmute.
This is for Jack and then for Mandy also. As in-home care and facility owners and executive director, we are generally hiring caregivers from the same pool. Basically, you know, we have the Coachella Valley. Are you finding that caregivers are adequately trained in the matter of sexual behavior, or do you think that it's something that needs to be addressed more for caregivers specifically?
Pat does our employee training, which we haven't done for a while, and that is a component of that. I think, as I mentioned a little bit earlier, you know, sometimes the younger caregivers are shocked that they're going to have to learn how to redirect sexual behaviors because they weren't aware that that was going to happen. But at the end of the day, it's very much like redirecting any other behavior when you take yourself out of that equation and don't take it personally, just like you wouldn't take, you know, when they call you fat or whatever, you know, attribute they decide to get you for. But yeah, it's definitely something that needs to be addressed and trained so that when it does happen to somebody for the first time, they're not totally left off guard and, you know, they have some idea how to react and what to do. And it's also important, you know, I think having this conversation today, you You know, people think we all hear people tell us, oh, I never thought I was going to have to deal with this. Oh, I never thought I was going to have to deal with that. And we don't know what we're going to have to deal with. Every new resident, I've been there 15 years. I think I've seen it all. Well, here comes the next person and they have something new you never even thought of. So yeah, that's inappropriate sexual behavior is part of that spectrum and part of what we need to train for.
I think that in our younger people that come in, they're not real sure what to expect when dealing with dementia. Sexual behavior being one of them, inappropriate language being another. I mean, just there's a variety of things that some of our newer caregivers aren't often exposed to or properly trained to deal with. So they may have been exposed to it. Maybe they worked somewhere else and were exposed to a certain behavior, but nobody really sat down, explained it, addressed it with them and how to handle it. So I feel like there's a lot of training we can do. And I know that Vista Cove has a training program like we do. That's very detailed for Alzheimer's and dementia care. And that's, to me, the key. You can plop somebody down in front of a video and tell them to watch this video and take this test, but unless you actually engage with them and help them talk through what just happened, they're not going to learn from that experience. They're only going to be, there's two ways you react to a new experience. One is with excitement, okay, I can handle this. And then the other is, oh my God, this is traumatic and I want out of here. So I think it's really important that when they've had this first experience with a patient, a client, that they have a supervisor, someone they can talk to about, okay, this kind of freaked me out. Like, I didn't expect this grandpa guy to come at me like that, because that's how some of our 20-year-olds feel. So once we talk about it and give them some extra training at that point, I think they really do start to get a good handle on, oh, this is something that's normal. It's something that I can handle, and now I know how to respond and redirect, and now I have a little more of an understanding as to why this person maybe did those things. So yeah, I think there's the older caregivers do have a little more experience with it. But again, I don't think talking about sexual behavior is something that a lot of companies do. So I think it is important that we talk about it like we are today.
And I think we can always provide more training. So on an annual basis, having a session with your staff about sexual behaviors is something that you really want to incorporate in your training patterns for your community. And I think, I've been amazed by staff, how open they are. Once you bring the topic up and have a discussion with them, they want to know how to deal with it. They want to know how to be respectful. They do understand that these are human beings and that they have needs and rights. They just didn't maybe know how to handle it or what to say. But once you provide that opportunity for them, and they know that they can come to you to ask questions of something if they need more training. But I think, as Mandy said, we can never give enough training to people that work with Alzheimer's and dementia people. So being able to offer this, I don't know a lot of facilities, I can honestly say that, that provide sexual behavior training. So that's something definitely that, Alzheimer's Coachella Valley could offer if communities want someone to come in, or Zoom programs. The more training, the better, the more comfortable they're going to feel.
I know we had talked about incorporating sexual behavioral training in the meaningful conversations course 1.2. We're still going to do something like that, aren't we, Pat?
Yes, and we that's a good reminder for those of you that are listening. We're going to be starting a new session in April on the 12th and the 19th. meaningful conversations. And this is basically a class. I mean, we do have professionals that come to it, but it's more for family caregivers and paid caregivers. And it's a two-part. So it's from 1 to 2:30 on the 12th and the 19th. And there's definitely a portion of that where we talk about this particular topic. And it's an opportunity for, family members and caregivers to ask questions, to feel more comfortable about how to handle situations at home, or even with their family members, neighbors and friends that, might come and visit, and those kinds of things. So yes, definitely, Don.
Good.
Do we have any more questions from our viewers today? All right.
Well, I really want to thank Jack and Mandy and Judy. And Jack and Mandy, if you want to share a little information, Jack, about Vista Cove and the services you provide. And then Mandy, if you want to talk about the home care resources and things that people can access, you're welcome to do it. You were kind enough to share with us, so.
All right, great, thank you. Vista Cove at Rancho Mirage is a 56-bed assisted living. As Pat mentioned, all we do is memory care. We take care of people all the way through the process. A couple of things that differentiate us from everyone else, besides the fact that that's all we do. We're located on 2.5 acres. About 2.3 of that is secure grounds that people are able to go outside. We have a lot of room outside, a lot of walking paths. A lot of people, wandering is considered a behavior issue. That's an activity at Vista Cove. We have a safe place to do that. We also have a really long-term staff. My director of resident services has been there 14 years. The day shift med techs were there when I started. We've replaced the evening med techs because they've retired from there. Had a lot of people retire from there. We have a pretty high staffing ratio. We have a caregiver for every 4 to 6 residents on the day shift, 6 to 8 on the evening, and 4 people there at night. So people tend to get burnt out in memory care. We have enough hands to do the work. So people are able to stay there, and they like what they do because they have the tools that they need to take care of people. So it's a good atmosphere. The property was built for memory care, so it's short hallways. You can see where you're going next. Physically it makes sense. You're not walking half a mile to get to a giant dining room. None of those sorts of things. Right now we are going to start doing respite again, which is short overnight stays. We don't have any minimums. Hopefully we'll be able to resume our day program soon. We do either a half day, morning or afternoon, or a full day, which is 8:30 to 4:30. They all include lunch. So hopefully the green light for that will go. A lot of people have been asking about that, and looking forward to that getting started again.
Thanks, Jack. Mandy.
Custom Care Solutions. We've been here in the Valley. Gosh, we're getting ready to go on our 9th year. We have a great staff. We have a large staff, all different types of people, men, women, all different ages. And we really do focus on giving our staff training, whether it be for dementia, Alzheimer's, Parkinson's, plastic surgery, hip replacement, orthopedic surgeries. We try to cover everything because oftentimes we're dealing with multiple issues, injuries, diseases, diagnoses. So our caregivers have to be really prepared for anything. And a lot of times what happens too is when we're in the home, maybe we start off going into the home for someone with Parkinson's, but then they have a fall when we're not there. And now we have a broken hip or knee or shoulder or something. So now we have to do the orthopedic care. So making sure that our staff is well-rounded and trained in all different areas is something that we really focus on. We are registered with the Department of Social Services and through the state of California. So our company's registered, and then all of the caregivers that work for us are registered with our company through the Department of Social Services. This gives them an FBI background check and registers them with the Department of Justice so that if something happens while they're working with us, we are notified that there was an issue and they can't work anymore. So that's something that I've been really happy to be a part of with the state. We do take out taxes and we provide workers' compensation, malpractice, liability. Yes, there is a minimum of hours. We do have a 4-hour minimum, but we also have a 1-hour visit. And the 1-hour visit, I used to call it a bath visit for lack of a better term, but the 1-hour visit can be anything that they can get done in that 1 hour. So if it's just a matter of going in and checking on somebody to make sure they're okay, making sure they had dinner or breakfast that day, whatever, took their medication, we can do that. I do like the 1-hour bath visit for a couple reasons. One thing is that we have often had dementia patients that maybe we have a male patient that prefers a female caregiver. However, he won't shower with a female. So one of the things I do like is that with that 1-hour visit, we can send a male over to do that shower and then go back to having who they like for the other activities throughout the day. It is very important, I feel, when you're choosing a company to come into your home that they are a legitimate, no, I shouldn't say legitimate, sorry, that they are a company that provides workers' compensation, malpractice, liability, that they are not independent contractors, that they are the employer for several reasons. When we talk about sexual behavior, this is a fine line. There's a lot of training now specifically for caregivers that talk about if somebody's sexually inappropriate, that caregiver has rights and they don't have to stay on the job. And of course, we never want anyone to stay on a job they're uncomfortable with. But if you're hiring an independent contractor, they can turn around and sue you for harassment, sexual harassment on a dementia patient. So there's things to me that are really important about making sure that you do, if you're going to use a company, that you do use a company that is an employer and has employees and that is not independent contractors, because you are out there on your own. And I have read blog after blog. There's groups on Facebook, rant and rave groups, and people constantly complain about, I had a so-and-so company, they're independent contractors, someone stole my mom's ring and it was my great-grandmother's ring and there's nothing they'll do about it. And they're right, there's nothing they'll do about it. They don't have to. So using a company like ours, you have a recourse. One, we actually can pursue it and press charges. 2, we have insurance to back up the cost of that item. Not that that replaces it, but you do have somebody that is actually going to be able to follow it through because that is their employee. So I think that's important to mention.
Okay, thank you, Mandy. Well, I want to thank all of you for joining us today, and especially our panel.
Thank you.
And everyone have a nice weekend and hope to see some of you again at some of our other programs.
See you Monday.